So good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Pena-Milnick, joined by my vice chair to the left, Bonnie Collison. Today's lawyer for the committee is Ms. Lisa Simpson to my right. Just to go through some very quick rules, will you please set your phones to vibrate so you're not embarrassed unless you have some really great music. That would be great. All bills that are Senate cross files of previously heard House bills will be sponsor only. The committee will accept oral testimony on Senate bills from the bill sponsor or sponsor's designee. For Senate bills that do not have a House cross file, please, we will hear from the bill sponsor, one witness in favor and one witness opposed to it. The public may submit written testimony to indicate their position for the bill. For my committee, if it's a bill that we have heard before, you know, your best question, if you really need to ask a question, remember that on this committee and others, we do a lot of our work in subcommittees. So if we rush through it, I don't want the members of the public to think that we have not taken the time to learn the bill. For the sponsors, if the bill is in the exact posture, please just let us know that. Members of the public are able to view this live stream on the Maryland General Assembly website and YouTube. And today we're going to start with my friend and colleague, the chair of the Finance Committee, Senator Beidel. And it is a bill titled Counties Cancer Screening for Professional Firefighters Require Coverage, the James Jimmy Malone Act. Good afternoon, Madam Chair.
Good afternoon, Madam Chair.
Great to see you.
Good to see you in person.
Yes, and thank you for working with us. We really appreciate it. I know you're doing a lot of work across the street, and we're really grateful.
We appreciate working with you. So, Madam Chair and Madam Vice Chair and members of the committee, thank you for hearing Senate Bill 374. You did hear the cross-file, but we've made some amendments that you didn't have at the time that you heard the cross-file. So if I can just spend a couple of minutes talking about those amendments. So we've named this bill the Jimmy Malone Act. Many of you have been here when Jimmy was here as the Vice Chair of Environment and Transportation. Jimmy was a firefighter almost his entire adult life, both as a paid firefighter and then as a volunteer. And Jimmy died with actually 2 cancers. He started out with leukemia, and they soon cleared it up, and then he had brain cancer. And I visited Jimmy a few times at the end, and it was just really sad to see such a vibrant person. But we know that firefighters are at risk for cancer at greater rate than other people. And so my bill, the idea of my bill actually came before Jimmy was sick this last time, but to actually have screenings done to try to detect cancers early, because I think you all know if you detect cancer early, you have a better rate of success. And of course, it's less expensive to treat in early stages. And so while the bill requires the early screenings in order to try to save money, because that's what it's been all about this session, isn't it? We're going to save money.
It is.
It's number one, the counties that are self-insured that are already doing these screenings for our firefighters, already doing the health care for our firefighters. It just asks them to add a few more screenings that the IAFF, the International Association of Firefighters, have added to the list of possible cancers for firefighters. And then there's a bill that the chair of Budget and Tax has that actually provides innovative screening money at $3 million, and that money could be used just for the blood test that can detect cancer. So in that way, we really have not added any additional cost to the state budget or county budget. So I hope that you'll consider this bill in honor of Jimmy Malone, and I'll be happy to take any questions.
Thank you so much, Madam Chair. I really appreciate your testimony. Are there any questions for Madam Chair? I think that I have now 21 members. I can tell you that the committee is very supportive and very grateful for your work. I knew Jimmy when I started serving here. We served together, and he had such an infectious smile, right? And smell great all the time with his cologne. So, this is really beautiful to honor him in that manner. So thank you so much. And I'm sure that we won't have any problems putting the amendments that you have placed on it, okay?
Thank you. And you have 21 members. I think I have like 2 members of my committee right now, so thank you for taking my testimony first.
You're welcome, and thanks again for working with us, okay?
Thank you very much.
Have a
great
blessed afternoon.
Thank you.
Oh, do you have another one? You have a second one.
Do I?
You have Senate Bill 371. It's the State Board of Pharmacy renewal notices, electronic means. Is that in the same posture?
It's a great crossfire, Madam Chair.
Yeah, it's in the same posture.
My chief of staff didn't see that on your agenda, so
Yeah.
I believe it's in the same posture
Yes.
as your crossfile.
Yes.
So I would ask that you also pass the Senate bill.
Absolutely, you have it.
Thank
Thank you
you.
so much.
Thank you.
Have a great day. This concludes the bill hearings on both Senate Bill 374 and Senate Bill 371. Have a blessed day, Madam Chair. Next, we have, who came after Madam Chair, so that I am fair? Senator Lamb, all right. Senate Bill 447, hospitals, emergency pregnancy-related medical conditions, procedures. You have, this is not cross. Okay,
It is not.
okay,
And I have Robin Elliott joining me here on the panel.
okay.
So good afternoon, Chair Pena-Melnick, and members of the Health and Government Operations Committee, here to be able to testify and introduce Senate Bill 447. Does not have a cross-file. For the record, Clarence Lamb, Senator District 12. So this is a bill that addresses provisions that are currently in federal statute called EMTALA. EMTALA is a longstanding federal law that requires individuals that are coming to an emergency department to receive any life-saving care that they need or be stabilized before they can be transferred. So it's basically an anti-dumping law that has been in place at the federal level for anyone to get emergency care treatment that they need at the emergency department, regardless of whatever hospital they come to. This law, which has been longstanding, has been thrown into a little bit of a loop here because of the Dobbs decision. So EMTALA has been enforced through many decades, and up until recently by the Biden administration. The Biden administration had issued guidance reminding hospitals that hospitals were required to provide life-saving abortion care. This is in the event that a woman's life is in danger because of a complication that they may have, that they would require an abortion. That the guidance that was provided by the Biden administration is that EMTALA requires these emergency departments to provide life-saving abortion care if it's necessary to save a patient's life or prevent a serious injury. And what has resulted under the prior few years is that there were multiple lawsuits working their way through the courts up towards the Supreme Court, although not yet, seeking to exempt abortion care from EMTALA, from the federal requirement that everyone receive life-saving care that they need at an emergency department. And we've had states fight these provisions as well, so those lawsuits are making their way up. They haven't quite reached the Supreme Court yet, but also with the new incoming administration, the Trump administration has decided that they will no longer require compliance for EMTALA on abortion care. So that's a huge change, because while the federal statute exists and it's still being adjudicated, this current administration has decided that it will no longer enforce EMTALA on abortion care. So this is not a theoretical issue. I think folks were wondering if this is something that might happen or will happen. This has happened, and there are steps that are taking place already that we've outlined. In your written testimony, you'll see a letter from Rachel Santos about her experience with a patient who initially sought emergency abortion care in another state. This patient was denied services, so she made a rescue trip back home here to Maryland. She was getting sicker as she traveled, and by the time she arrived back at a hospital in the state of Maryland, she was septic, meaning that she had a dangerous blood infection. Luckily, despite this delay, she was able to receive the life-saving care she was able to receive care that saved her life. Additionally, in the Senate hearing, there was oral testimony from an OBGYN about the importance of emergency abortion care as well. There was also a story reported in the USA Today about a Maryland woman being denied emergency abortion care at St. Agnes, at one of our hospitals here. The concern here, I should be clear, and I think I left this part out initially, is that with the federal statute of EMTALA, all hospitals were required to provide life-saving care that included abortion care. The concern here is that most of the hospitals have been fighting these provisions. There are many faith-based institutions or hospitals where up until these recent changes, they were also required to provide life-saving abortion care when a woman's life is at risk if a woman ended up in their emergency department. And the cases here oftentimes stem from women who might need emergency care, thus they're being transported by an ambulance, meaning that they have no say in which hospital they go to, and the ambulance might transport them to a faith-based institution or hospital. And if that hospital has their own policies that prohibit abortion care, even when a woman needs that to save her life, that's where it runs afoul of the federal EMTALA statute. But because the federal statute is no longer being enforced, this is why this bill is coming forward as a local bill, as a state bill, to put in place the requirements of EMTALA back at the state level. When it comes to pregnancy-related emergencies, these do occur. So about 2% of pregnancies are ectopic pregnancies, and about 3% of pregnancies result in preterm, premature rupture of membranes, so basically early rupture. We believe that we must act to protect this access to life-saving care and cannot solely rely on these federal statute that's been in existence for a while and is now under risk to enforce this on any hospitals here in the state of Maryland. So basically, this bill seeks to codify the protections of the federal EMTALA law, and based on feedback from the hospitals, this bill was narrowed and also amended to a point where currently the hospitals are neutral. And we oftentimes get the question whether there is still a provision for individual providers. The conscience clause, different part of the statute, still continues to exist. And so that's basically the provisions of the bill. I know there are many differing opinions on abortion in this committee, but this bill is only talking about scenarios where a patient is so sick that they need an abortion to save their life or to prevent permanent injuries such as loss of future fertility. Marylanders cannot tell an ambulance where to take them in an emergency. They're basically transported to the nearest hospital. If that happens to be a faith-based hospital that is not compliant with EMTALA, their life might be at risk because they may not be able to receive the abortion that they need in order to save their own life. And so that's why this bill is coming forward now, and would ask the committee for a favorable report. Happy to take any questions.
Thank you. I know that you get one witness in favor, so why don't I allow Ms. Elliott to give her testimony, and then we'll open it up for questions, okay? And those of you that are waiting, thank you for your patience. Those of you that testify in opposition, as you know, we're very fair here. After we're done with this panel, we're going to call you as well. Ms. Elliott, go ahead.
Good afternoon. Robin Elliott. I'm here today representing the Women's Law Center of Maryland and the Maryland affiliate of the American College of Nurse Midwives. And as Senator Lamb said, unfortunately, this problem is not theoretical. As Senator Lamb said, all this bill does is take a provision that is in federal law and codify it in Maryland law. And that is to allow the state to enforce it. If the federal government is no longer going to enforce the fact that abortion care is required under EMTALA, we have no other choice than to make it a state law if we want to protect access in Maryland. And as Senator Lamb said, when any of us or our family members go to an emergency room, one, if you're driving, you're going to the closest emergency room. If you're taken by ambulance, they have a whole system which determines where you go. You don't get a say. We need to make sure that everyone, no matter where they go for emergency care, can have access to abortion care if they need it to save their life or health. And with that, we would ask for a favorable report.
Thank you. I see questions first. I saw Delegate Chisholm, followed by Delegate Olson, followed by Delegate Hutchinson.
Thank you, Madam Chair. And thank you, Senator, for bringing the bill. You talked about ectopic, and, you know, I remember my wife had an ectopic, and it's a scary situation. But so right now you're telling me if somebody had an ectopic and it ruptured, and they went to St. Agnes or Mount Sinai or one of the other faith-based, that they would be denied? Is that the way you understand it happens right now?
They could be denied. It doesn't say that they must be denied, right? So it depends on the policy of the institution, right? But there have been instances, for example, one that was referenced in the USA Today that was reported at St. Agnes, where a patient was denied life-saving abortion care that they needed.
Okay, but I'm just assuming, and that's why I wanted clarification, that when we're talking about ectopic, that's a little bit different. When somebody's later term, then obviously there's more conscious, I guess, that would come into play. We talk about ectopic, we're talking about safety. It is an emergency for a pregnant woman during an ectopic when it ruptures. So, okay, just wanted to.
There are a lot of instances where you could have emergencies that might occur,
Right.
like premature rupture of membranes.
Okay, thank you, Madam Chair.
I have Delegate, was it Hutchinson? Okay, Hutchinson. Sorry, they have your back.
That's very kind. Thank you, Madam Chair. Thank you, Senator, for being here and bringing the bill to us. I'm always just take notice when I see MHA, see Johns Hopkins, see University of Maryland Medical System opposed to the bill. They show that there's some inconsistencies, that they could be penalized by not following it. Is that still the case? And why would you say that? Are they still opposed to it?
No. So they're neutral on the bill now. Because we've worked out a lot of the provisions that originally the bill basically wholesale took the federal statute and dropped it into state statute. We've cleaned this up to just narrow it just to the basic elements that are needed. And with that, the Hospital Association, the hospitals have been neutral.
Thank you. Thank you, Madam Chair.
Thank you. Delegate Alston, followed by Hill.
Thank you, Madam Chair.
You're welcome.
With our constitutional amendment enshrining the reproductive rights and freedom of women, why is this needed? Because if they're violating the Constitution and not providing life-saving care, what is this bill going to do that's going to change them from not violating the laws that they're currently violating?
I don't think the constitutional amendment requires hospitals to provide life-saving abortion care, which is why this law would be needed. The constitutional amendment addresses a different, kind of constitutional right for women to be able to make a choice about their body, but it doesn't dictate how the type of care that hospitals need to provide.
Okay. So in the example that you gave for St. Agnes, was that an ectopic pregnancy or a late term?
I don't know the detail of that offhand. If you Google St. Agnes USA Today and EMTALA, you'll find that article, and they may have some more details about that.
Okay, thank you.
There are a whole host of different medical conditions that can result in pregnancy-related emergencies. So ectopic is one of them that was referenced. You could have preeclampsia, which is more prevalent. You could have sepsis, which is that blood infection that we had voiced earlier that was less prevalent. You could also have premature rupture of membranes and other types of pregnancy-related emergencies that could really threaten the life of the mother or her ability to have future children.
Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you, Senator, for this important bill. This question is for Robin, Ms. Elliott. So my understanding is that the goal here is to set things with respect to a hospital's responsibility to what it would have been, say, 6 years ago, right? Okay. So 6 years ago, what would typical Catholic hospitals do with an emergency?
So this is, it's 6 years ago or as early as December 2024. Hospitals all set their own policies. Religiously affiliated institutions are no different. However, all hospitals have to follow the federal EMTALA law. What has changed in January is that the law is no longer being enforced as to apply to abortion care. So we are in an unknown about what would happen if there was a case in Maryland, whether or not the federal law would be enforced. So that's why it's important to have a state law that gives the state control about whether or not to bring a case.
Right, thanks for the clarification. If I may, Madam Chair, okay, so I understand that, and I support the bill. What I'm confused about, looking at the testimony and reading the language in the amended version, is there is suggestion that prior to January 2024, the hospitals, say a Catholic hospital, would have some leeway on how they handle it, provided that the health of the mother, et cetera, was preserved, and that the way this bill is written, they're actually required to perform abortions if that's what's necessary, and that's saying that they didn't used to have to do that, they could do other things. And that's what I'm trying to clarify. Are we setting it back to what they used to have to do, in which they're saying they never were required to perform abortions, and this suggests that they would be?
So
that's what I'm asking, yeah.
I understand the question. It's a good question. My understanding of EMTALA is that hospitals, up until now, under EMTALA, all hospitals would be required to provide abortion care in order to stabilize a patient or in an emergency. So regardless of what the hospital's policies are, if they fail to do that, they would be subject to the penalty of federal law. So, so that means until this point in time, Catholic hospitals have been required to provide abortion care when necessary. And this law is trying just to keep that as the status quo by allowing the state to enforce that.
Okay, thank you.
Any other questions? Delegate Ross.
Hi, thank you, Madam Chair. This is just a very simple question. So right now, this would allow us to enforce it here, unlike, obviously, the federal government's not doing this. If there was a rollback of this act completely on a federal level, does this law have any teeth at all for us here in the state of Maryland?
Yes, because this is not dependent on the federal law. That's the whole point of the bill, is to make sure that we as a state can enforce a similar provision if EMTALA at the federal level was either not enforced as it currently is or struck down by the Supreme Court in relation to abortion care, which is a fair likelihood based on the court cases that are working its way through now.
Yeah, so if it's struck down, though, doesn't that supersede any state laws?
The current federal statute says that all life-saving care needs to be provided in emergency departments, and that would include abortion care. It's no longer being enforced because the Trump administration doesn't believe that it should include, that their interpretation is that it doesn't include life-saving abortion care. If that entire provision is struck down, passing this would allow that requirement to still stay in place at the state level, so that any woman, regardless of which hospital they are transported to by an ambulance, would still be able to receive any life-saving care, including abortion care, that they need at that institution to save their life or to prevent permanent bodily injury. So this would put that provision back in place. And to Delegate Hutchinson's question, yes, MHA is neutral. MedChi is support as well now. So a lot of the amendments have addressed some of the questions that have come up.
Did you have anything to add to Delegate Ross's question?
Thank you for that. And I would just add, Delegate Ross, that the state has the legal authority to set facility requirements of a broad range, regardless of what happens on the federal level. So this bill definitely falls within the purview of what a state legislature can do.
That's helpful, thank you.
And there are also enforcement provisions in this bill too.
Okay. Any other questions? All right, seeing none, thank you very much. We do have an unfavorable on the bill, and that is Ms. Laura Buckley. Maryland Right to Life.
Good afternoon, Madam Chair and members of the committee. My name is Laura Bogley. I'm Executive Director of Maryland Right to Life. It's good to be with you here again today, now that you've got some of that budget mess behind you. I just want to clarify some of what you heard in the proponent's testimony. This bill is not necessary to protect women, pregnant women experiencing medical emergencies. The federal EMTALA statute is not about abortion. It mentions birth several times. It never mentions abortion. What they're talking about codifying is the Biden administration's interpretation of the EMTALA statute, which expanded to try to force hospitals and medical providers to provide or complete abortions against their religious freedoms and rights of conscience. So this bill is a direct attack on religious freedoms that are guaranteed by the First Amendment and protected under Title VII of the Civil Rights Act of 1964. By enacting this law, you are going to make hospital administrations choose between violating their employees' civil rights or being fined significantly by the state. This bill would force hospitals and emergency room physicians in violation of the rights of conscience and their oaths, Hippocratic oaths, to complete induced abortions under the guise of medical emergency. Induced abortion is not medically necessary. It's never medically necessary. And this is why transparency in language and statutes is so important. Induced abortion only has the purpose of killing the life of the unborn child. There is no law in any state that prevents any medical provider from providing life-saving care for a woman experiencing ectopic pregnancy or other medical emergencies and abortion. By enacting this law, you're buying into that false narrative, which is a fear tactic to scare women into these procedures. Now lawmakers want to force the hospitals and medical providers to clean up after dangerous abortion procedures because of the deregulation. We're seeing a large number of people reporting to emergency rooms because of failed abortions and the abortion pills, which are unsafe for women. We urge your unfavorable report. Thank you.
Thank you very much.
Any questions?
1 second. I'll ask. 1 minute. Are there any questions for the witness? Okay. And thank you. Thank you very much.
Thank you.
You have a blessed day.
You as well.
Thank you. Amen. I see Donna Kaufman, but I do not see her here. So this actually will conclude the bill hearing on Senate Bill 447. Thank you so much. Delegate Senator Lamb, can you come to the back for a minute for me? Thank you. I'm going to call, who was the next, I want to be fair, the next senator. I don't know what order you guys came in. All right.
Madam Chair.
Can say we don't treat you well.
No, I appreciate it, Madam Chair.
All right. This is actually Senate Bill 740, correct?
Yes, ma'am.
And it's the Healthcare Facilities Service Member Community Members SFC Matthew Fast Act. This is not cross, correct? And you have one witness, so you can get started.
Thank you.
My pleasure, and welcome.
Thank you. Madam Chair, Madam Vice Chair, esteemed committee members of the Health and Government Operations. For the record, William Folden, State Senator representing District 4. SB 740, this bill is a little personal to me. So every day I wear a bracelet, and every day I'm reminded of the loss of someone too soon, Matthew Fast. Matthew was like a little brother to me. He basically lived in my house the first 12 years of his life, and Matthew became a soldier because of me. Matthew became a police officer because of me, and Matthew died far too young at the age of 29 years old. The Sergeant First Class Matthew Fast Act for Warrior Healthcare requires Maryland healthcare facilities to systematically identify and respond to the unique needs of our veterans, service members, and their families, collectively called the warrior community. By designating this population as vulnerable, the bill mandates screening and better data collection to prevent missed diagnosis, improved outcomes, and honor the service of those who have served or are serving. This approach aligns with existing state and federal healthcare equity requirements, ensuring minimal administrative burden and maximum impact on patient care. This bill addresses the civilian care gap regarding our veterans. So over 80% of veterans receive some or all of their health care outside the VA, making this systematic screening crucial. This leverages existing frameworks by aligning with current state and federal standards to address health disparities. And for screening for military service, by simply asking, have you served, this bill will allow the screening of our service members and their providers to catch conditions related to combat exposure, toxic substances, and stress before they become critical. This bill also honors Sergeant First Class Matthew Fast's memory. This legislation was inspired by a preventable tragedy, turning a loss into a commitment to protect others who have served. So in a moment, I'll turn it over. This is Jessica Fast. This is Matthew's widow. She learned that after Matthew passed away at 29 years old and after several years of attempting to have children, she learned the day after we buried Matthew that she was pregnant with their first child. And thankfully and gratefully, we have Matthew Little Foo, as I call him, the second, just like I called his father Little Foo. But this bill, the main purpose of this bill is that the Sergeant First Class Matthew Fast Act ensures that Maryland healthcare facilities recognize and address these unique needs. Veterans and service members of their families who often rely on civilian healthcare, by just identifying them as vulnerable, it just mandates them to ask that question. That's it. Because if the question is asked, have you served? Then it may prompt other discussions. Where have you served? Were you exposed to toxins like Matthew was? Were you exposed to some of the burn pits like Matthew was? Were you exposed to combat? Do you sleep well? Do you have night terrors? These are all affecting these warrior community, their health, and it affects their families. The warrior community includes active duty, National Guard, reservists, veterans, and their families. Nearly 1 in 5 Marylanders fall in this community as a part of this warrior community. Because of these the aforementioned areas that are exposed to our service members, military service members are seeing an increased risk of heart disease, stroke, certain cancers, post-traumatic stress disorder, and respiratory illnesses, often due to combat exposure and the toxic substances. Recognizing the veterans and the service members as a vulnerable group ensures healthcare providers proactively screen for these issues, preventing late-stage diagnosis and saving lives. And with that, I think that's the point of this. Our service members, men and women who go away protecting our freedoms, our liberties, and championing democracy across the globe, when they come back home, we just need to make sure we're doing our best to ask this simple question, have you served? And with that, I'll turn it over to Jessica Fast, but I would ask for your favorable report on SB 740, and I'm happy to take any questions once Jessica's finished.
Thank you, Senator. Good afternoon. Chairwoman, Vice Chair.
Good afternoon.
And members of the Health and Government Operations Committee. As the Senator said, my name is Jessica Fast, and I'm here today in support of SB 740, the Sergeant First Class Matthew Fast Act. My husband, as was mentioned, passed away suddenly at 29 years old from an undetected heart condition. We believed he had a simple illness, but because the unique risks associated with his military service, were never considered, healthcare providers missed our chance to save him. Only days after his death, as you learned, I found out I was pregnant with our son, Matthew, and he will only know his father through memories. My hope is that through this bill, other families will not experience the same. One simple question, have you served, could have changed everything. If providers had known to ask about his exposures during deployment, they might have recognized early signs of something serious. With more than 500,000 Marylanders who've served, still serve, or affiliated with military service seeking care outside of the VA, these risks go unseen far too often. This bill ensures healthcare providers know when they're treating a member of the warrior community by designating them as a vulnerable population. No heavy cost or administrative burden, just a critical step to save lives. This bill aligns with existing standards and addresses serious conditions like heart disease and cancer that disproportionately affect veterans. Because of the unique demands of their service, veterans experience significantly higher risks compared to non-veterans. 85% more ambulatory disabilities, 43% more likely to develop impairment, cognitive impairment, 40% more likely to develop cardiovascular disease, 380% more likely to experience hearing loss, and 25 to 80% higher risk of various cancers.
You can take your time. No need to rush. Go ahead.
Okay, thank you. I thank Senator Folden for his service to our country, as well as the many co-sponsors for championing this measure. Honoring my husband's service and sacrifice means preventing other families from experiencing the pain my family has endured. I urge you a favorable report on SB 740. Thank you for your time and consideration.
And
Thank
Madam,
you for being here.
Madam Chair, if I may, I just want to, the reason that this bill, from this personal example, is important is that Matthew Matthew was 6'6", 260 pounds, 50 pounds. He was a wonderful being. And he went to the doctor the weekend before he passed away.
On a Sunday.
On a Sunday. And they thought he had cold-like symptoms or flu-like symptoms, and they sent him home. They never asked the question. He went back, it was two visits really close, right before he died. And again, they were like, no, you just got this virus.
They tested him for strep because he thought he had strep, and they said, you don't have strep, and they sent him home and just told him to take medicine from over the counter and get rest. And 3 days later, he had gone to work as a police officer, and that night he came home and he did not wake up.
And so this is an example of, maybe with this one simple question being asked, we have a service member who didn't get to see the birth of his son, didn't get to celebrate and rejoice in the knowing that he had a son, and they could have tested and been and known that there are certain elements of heart disease that are associated with these burn pits, with these exposures, and they would have asked and maybe treated him differently. And that's all. Thank you.
Thank you. I want to tell you thank you so much for being here and sharing your personal story.
Thank you very much.
I wouldn't even want to imagine what it's like to lose your spouse, let alone be pregnant. So my heart goes out to you.
She's an amazing mother.
We appreciate you being here, okay?
She's an amazing mother of that little 8-year-old young man now who looks the spitting image of his father.
She's very blessed to have your love and support as well.
Very, very blessed. Yes.
Are there any questions? I see Delegate Johnson, followed by Vice Chair Collison.
Thank you, Madam Chair, and thank you, Senator, for bringing this bill. The question I'm going to ask is if you know the answer. Do our service members get a screening before they're discharged, and is that put on their medical records, and do their medical records follow them outside the military? Because this happens way more often. And
it does.
We need to get more out in front of this to where we could possibly get these service members directly upon discharge to services, medical services that they need.
Thank you for the question. And let me just say that this is an opportunity to put Maryland as the tip of the spear in its recognition and how we address our service members and their ailments. The VA records are very difficult. As a veteran, I have sought treatment within the VA. I get treatment outside the VA. My doctors outside the VA are often saying, don't even worry about trying to get me your VA records because I can't get them. Tell me what you can about your service. So in the effort of just streamlining this and unilaterally asking these providers to just ask this question, then it puts its stamp at that time on their civilian record for the other doctors to be able to know as this person navigates through the civilian side of the healthcare industry. And I think that's the main component about this.
Yeah, and to answer your other question, service members are required to obviously train for physical fitness prior to entering service, throughout their service, and then certainly they're measured upon leaving, even if it's in a duty station, coming off of active duty, or when they completely separate from the military. So it's one of few professions where you're required to go in extremely healthy and you come out extremely unhealthy. And I can tell you from our experience, my husband served 2 tours of duty. Before his second tour of duty, he had gone through the police academy and had a full physical aptitude test and came back clean. After he returned from a 12-month tour in Afghanistan, there was an unusual mark on his heart testing. I didn't even know that until after he had passed away. That record lives only with the military that never saw any other civilian doctor. And we are a reservist family, so we seek most all of our health care through our local community health care or an urgent care clinic. And so this would require them to not only screen, but it follows that question, and that their answer follows them on their electronic health record. So no matter where they go, everyone will be flagged that this is someone who has served or has an affiliation to military service.
Thank you. Thank you, Madam Chair.
Chair Collison, you're welcome, followed by Delegate White-Howland.
Thank you, Madam Chair. And as the daughter of an Air Force veteran who ultimately succumbed to exposure of Agent Orange in Vietnam, I am very grateful for the bill. My question is, are you aware of any kind of protocols or template screenings that physicians could use? That's number one. And number two, if you don't know the answer to this, then it's a question I think we need to put out there in the public. Is there a level of awareness around the needs of former service members, the health needs of former service members in the medical professional?
So those are great questions, Delegate, and I'll take a stab at it, and I'm sure she'll clean me up if there's anything. But the protocol screenings or the protocols or the screening, that's what this is about. It's just adding that one more element to their screening list when you are being seen by a physician. Because, a lot of veterans, you're gonna be shocked by this, but a lot of veterans are stubborn. They go into the service, your father included, I'm sure. We go into the service, we come out, we're wholly not as healthy as when we went in. And we're like, it's a part of the service. I knew what I was signing up for. This is part of it. And what we've done, and I don't want to act like we're bashing the service here at all, because I'm not. I'm extremely grateful for my opportunity to serve and those that have served and your father. But from the time that your father and his service with Agent Orange, when those service members came home, it was a completely different process to the delegate's comment about what do we do when they return home, because they didn't do anything when you're right. So when I came home, we just were like, hey, we're going to check your ears. Oh, you're deaf. We're going to do this. Oh, you've got this. Okay, we're going to check these blocks. You're definitely not as good as you were, but you're eligible to be out. They do that screening as you go in and as you go out, because they see that range of disability rating or decreased abilities. How's that? And now I want to say that after, unfortunately, we're on a two-front war for 20 years, we've seen these screenings actually become quite good. The problem is when the service members are now coming home, they're being offered services for PTSD. They're being offered services because of night terrors. They're being offered these things that we've never done before, right? However, when they leave that system, like Matthew did. Matthew didn't stay in the VA-only healthcare system where they knew and ultimately died as a part of a heart-related issue. Those questions aren't being asked outside that because we don't know, and no one's requiring them to. So to your second point, this would do that. It would put that on there, and we would allow us to say, hey, this is my service, this is where I was. And these doctors, by virtue of that, will also become better informed and educated with the diverse and exposures that our veterans, our warrior community are exposed to, making them better service providers to those service members who don't want to stay in the VA healthcare, because some of us don't. I mean, it's just, I don't know.
Yeah, certainly, if we could build a wish list out of this bill, it would include more regular education and requirements for healthcare facilitators to understand some of those unique needs, to know that men over the age of 60 are more likely to have prostate cancer, but if they're a veteran, it's more like 50. It's significantly higher, so they should be tested prior to that. So that education, that would be part of the wish list. Ultimately, it's just understanding and knowing who your patient is by asking that question. Yep. And our hope is that then the provider now knows their responsibility to fully care for that individual and know their unique history in the same way they ask you your exposure to lead paint and your paternal grandfather's medical history. And so, yes, I think that more can be done to educate, but I think this is the start to do that.
And Madam Vice Chair, I do want to close this up, is that your question is very well noted in that there was an effort originally in the original crafting of this legislation to include the tracking of this through MDE as far as how our population is being affected, but it had like $150,000 fiscal note with it. So look, so that, right. So we're understanding, and we can peel that out for now, right? Because now with it, the way it's written now, there is no fiscal note. It's just asking them to ask the question.
Okay. Thank you very much, Senator.
Thank you.
Thank you, Ms. Fast.
Thank you.
Delegate White-Holland, followed by Delegate Bagno.
Thank you, Madam Chair and Senator. Thank you for bringing this bill, and Ms. Fast for also being here. I, too, come from a military family as well, and so I really am passionate about and certainly do care about our veterans and our military families. I wanted to know, because you are also elevating some of the other more macro and global issues when it comes to being able to access the appropriate medical information. And so I wanted to know, have you had any engagement with Secretary Woods and the Department of Veterans Affairs and military families? Because I see that there is a letter from the Health Department, but I see how these issues also cross with other departments. And also wanted to know if there's been any engagement with our Veterans Caucus, where I know these issues are also therein. So I just wanted to know what further engagement you're having either on this bill or some of the other global issues that you've elevated in your testimony.
Sure, that's a great question. Thank you for that. As far as, so this hearing has gone way better than the last one. And the last one I was a mess, I'll just tell you. And I admire her courage and strength on how she comes out here and speaks on behalf of Matthew. The Health Department wrote their letter in. I am noticeably and surprised as you are with the absence of the Veterans Administration of Maryland not having a letter there. As far as the Veterans Caucus, I did not actually reach out to them, and I'm on there, and right, that's probably on me. So that is my failing on that one. But it has been observed and not without question and concern that there was no comment or input from the Maryland VA.
Madam Chair, if I may follow up.
Sure.
Just very quickly, is there interest or desire on your part to reach out to the administration and the Secretary to see if there is a willingness to address some of these global issues, certainly for future sessions?
Sure. I'm all about that. I think that's what makes these bills even better, is that collective input. So thank you.
Okay. Delegate Bagno.
Thank you, Madam Chair, and thank you, Senator, for this bill. I know working in behavioral health, so often we see a disconnect because behavioral health isn't integrated into VA benefits, VA services. I just had a question because I noticed that the Maryland Military Coalition didn't weigh in, and often we have bills before us where there is a discussion of armed forces and uniform services. Would you be amenable to including uniform services so that we don't have a future where we have to come back and amend them into the bill?
Of course, and I actually thought that was a part of the language that they were transitioning over to anyways. So yes, obviously, it's important that those that are serving in these theaters are getting the proper attention when they come back home.
Thank you very much.
Thank you.
Senator. Thank you, Madam Chair.
Okay. All right, I don't see any other questions. Thank you so much
Thank you,
for
Madam
being with
Chair.
us. Again, thank you so much
Thank you all very
for
much. I really
being
appreciate
here,
it.
and I'm so sorry on behalf of the committee. Sorry about your loss, okay?
Thank you very much. I appreciate
Thank you. This actually will conclude the bill hearing on Senate Bill 740. I believe the order I saw was Delegate West, right? Senator West, sorry, you're always our delegate. You came from HGO. We claim you. Followed by Senator Kramer and then Senator Hershey, right? Okay. Want to be fair. Good afternoon. And this bill is not cross, so you have, we're going to give you 4 minutes to present to us, and then 2 minutes for the supporting witness, okay?
Thank you, Madam Chair. Let me start by saying it's always a pleasure to be back in HGO. While I was waiting, I texted your former chair, and I said, I'm sitting in HGO waiting to present a good bill, thinking of our years here together. And she sent back a very warm response. So I feel great to be back before you again. So this is Senate Bill 956. This is one of those unusual bills that was brought to be by a constituent who identified a problem. Now, frequently when constituents identify problems and I look into it, their ideas aren't very good. The more I looked into this bill, the more I realized these ideas are really good. The problem is in providing a certain kind of insurance known as Medicare supplement insurance to Medicare beneficiaries in Maryland. Many Maryland Medicare recipients, hundreds of thousands, have made the choice to purchase Medicare supplement insurance upon becoming covered by Medicare Parts A and B. Medicare supplement insurance provides a vital method for filling gaps in Medicare coverage. Without this type of insurance, Medicare beneficiaries would be subject to literally hundreds of dollars in additional payments each year just to get the basic coverage they need. While there is no apparent problem in choosing and procuring Medicare supplement insurance, when an individual first qualifies for Medicare, problems do occur later on. The reason for such problems is that Medicare supplement insurance is not medically underwritten when it's first procured. In other words, the Medicare recipient is able to obtain it on a guaranteed issue basis during what's known as the open enrollment period. This is not true, however, several years later when the cost goes up substantially and the recipient wishes to switch carriers. Those policies are medically underwritten, and they may be difficult for an individual to qualify for due to medical conditions. Now, in 2023, Maryland fixed part of this problem by introducing something called the birthday rule. Under the birthday rule, a person may switch carriers as a matter of right on a guaranteed issue basis once a year around his or her birthday. The part left unfixed here is that some carriers who may be reluctant to accept these applicants, although they're required to do so, have instead reduced by up to 90% the compensation payable to the health insurance brokers who advise Medicare beneficiaries and work with them to obtain the best insurance suitable to their needs. At such a very low level of compensation, brokers simply cannot afford to spend time working to obtain Medicare supplement insurance on behalf of persons seeking to exercise their rights under the birthday rule. Now, I'm not here to support any particular level of compensation for insurance brokers. I believe the market should do that. At the same time, we must recognize that brokers spend a lot of time educating themselves about their profession, becoming licensed, learning about the insurance products that on offer, keeping up to date on changes, and generally providing valuable advice to Medicare beneficiaries who need it. And we should not expect insurance brokers or any provider of products or services to offer those products and services at an unfairly low cost. It's also worth mentioning that the primary market for Medicare supplement insurance is older. This is often a population accustomed to seeking personal service from a knowledgeable professional to help them make a decision in a complicated health insurance transaction. So Senate Bill 956, which is really brief, simply requires a carrier to pay the same commission during a guaranteed issue period, the birthday rule, as it does during an open enrollment period. With that, I just finish by saying there was no opposition to the bill in either house. There's no fiscal note. The MIA amendment was adopted in the Senate. The Finance Committee adopted this bill unanimously. It passed unanimously on the floor of the House. Al Mendelson, who recommended the bill to me, is sitting behind me, and Bryson Popham is next to me to provide further information. I hope for a favorable report.
Thank you very much. I appreciate it. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Bryson Popham appearing before you again on behalf of the National Association of Benefits and Insurance Professionals in support of Senate Bill 956. In 2023, you in this committee and in this legislature did a very good thing. You passed something that's colloquially, pronounce that correctly, known as the birthday rule. And what that does is provide people in need of an essential product, that is Medicare supplement insurance, access to that product. Senator West laid it out for you. When you first qualify for Medicare, you can obtain Medicare supplement insurance without any medical underwriting, and it's easy to do. We're not talking about age 65 people. We may not even be talking about age 70 or 75 people. The examples that were given on the Senate side were people age 80, people who acquired their Medicare supplement insurance maybe when they were 65, but now their needs have changed. And equally important, the price of the product has changed. They do, as Senator West pointed out, need to have assistance in selecting among these products. And what changed between 2023 and today, as Senator West also said, is that the compensation available to brokers to provide this service was reduced dramatically. I've been in this business for a long time. I've never seen such a significant reduction in commissions, and it's unfortunate, but you have a chance to remedy it with this bill. There is no opposition from the industry that I'm aware of, and if you pass this bill, you're going to be doing a good thing for people who need Medicare supplement to take care of their medical needs. So I'd respectfully request a favorable report on Senate Bill 956.
Thank you. Are there any questions for the sponsor and his panelist? All right. You must
Thank you, Madam Chair.
Clear.
Thank you very much.
Thank you so much. There are no further witnesses. This concludes the bill hearing on Senate Bill 956. Have a great day. It's always great to see you, my friend.
It's great to see you.
I have next Senate Bill 748, Senator Kramer. And this is Public Health, Alzheimer's disease and related dementias, information and prevalence and treatment. If your bill if it's in the same posture, please just let us know that, okay? Thank you.
Thank you, Madam Chair. Ben Kramer introducing Senate Bill 748 in the same posture to the best of my knowledge as the House cross-file HB 1004.
Thank you very much. Excellent testimony. Any questions on a bill that is in the same posture? Seeing none, thank you very much. This concludes the bill hearing on Senate Bill 748. Senate Bill 376, Health Facilities Delegation of Inspection Authority, Nursing Homes.
Thank you, Madam Chair. And this one, unfortunately, is not going to be quite as simple. Ben Kramer introducing Senate Bill 376. It is an issue, colleagues, that you are somewhat familiar with. But I want to quickly go through numbers here and start clarifying what's fact and misrepresentation. To begin with, colleagues, the state of Maryland, via a contract with the federal government, is now responsible for inspecting nursing homes. The minimal inspections in Tier 1, and there's 4 tiers of inspections. Tier 1 is a federal requirement that the nursing homes be inspected at least once every 16 months, preferably every 12, as is required by state law. The fact of the matter is, the Department of Health has failed the most vulnerable in our communities residing in these nursing homes and their families miserably, miserably. 2 years ago, we were ranked dead last in the nation for inspecting nursing homes, tied with the great state of Kentucky for dead last. 1 year later, we were no longer dead last. We were second to dead last, tied with the great state of Alabama in failing to do nursing home inspections, not because we got better in Maryland, but Kentucky actually got worse. So I will share with you that I was able to get information that the state has been receiving over each of the past 5 years roughly $3.5 million from the federal government to do just these nursing home inspections, nothing more. However, we don't know how that money has been used because, quite frankly, the nursing home inspections are not happening. Now, I will share with you, this is of particular interest to me, because in Montgomery County, for 20 years, Montgomery County, on behalf of the state, did the nursing home inspections and ate 60% of the state's cost. So the state was getting the funds, but Montgomery County was eating 60% of the costs because we wanted to get these nursing home inspections done and had a perfect record of doing it. Since that agreement, that contract of 20 years terminated in 2021, Montgomery County has been averaging each year 1 inspection to 3 inspections of its 34 nursing homes. That's each year. We're either getting 1, 2, or maybe 3 inspections done. Now, the county has been pleading with the state, let us get back into the business of doing this so that we can ensure and put eyes on these nursing homes. I will tell you that today the only opposition coming up here is going to be the department that has failed every jurisdiction in the state of Maryland. It's not just Montgomery County where the nursing homes have not been inspected. It's every single jurisdiction. Your most vulnerable are being failed. The department has fought me tooth and nail. Even the nursing homes came into the Senate, Madam Chair, and said, we support this bill, please get us inspected. Only the department has opposed it. And I will share with you that they created what I unequivocally say is a false fiscal note in their effort to defeat the bill. The reason the bill came out of the Senate was the Senate took a look at that fiscal note and decided it defies logic. And Madam Chair, with your indulgence, this is really something that probably needs another 5-6 minutes of conversation, because I would really like to dispel some of the myths that were presented to this committee when the House bill was introduced. But that's to your indulgence, Madam Chair.
I'm going to give you 3 more minutes, okay?
All right, real fast, colleagues. As of this past December, I believe it was your committee and a Senate committee met to discuss this, one of many issues. This was the topic. As of the middle of December, 3 months ago, the Assistant Secretary stated the following. Of 222 licensed nursing homes, only 47 have been inspected in fiscal year 24. Along with the inspections, the state is playing catch up on thousands of complaints. The Deputy Secretary just 3 months ago stated that estimates show it will take 2 to 3 years. 2 to 3 years. That was the statement 3 months ago. My understanding is that statement has changed. There were 6,000 complaints waiting to be investigated just 3 months ago. Now, real fast, this is the kind of gamesmanship we've been up against. The department and the deputy secretary sent this committee and the finance committee a statement that said there are legal barriers to this bill. One of those legal barriers, and I quote, says, the state is not permitted into any subcontract without prior written approval from the secretary. And they're absolutely right. That's in the federal contract. But here's what they did not share with you or our committee. If you look at the appropriate place in that same document under the definition of subcontract, it states subcontract does not include an agreement with a local government. So this is the gamesmanship. They tell you they can't do it because they're not allowed to subcontract. And they quote from that. What they didn't tell you is if you go to the actual definition of subcontract, it says it doesn't include a local government. So yes, they can, and they did for 20 years with Montgomery County. Next, the deputy secretary stated over his signature that there are strict CMS guidelines requiring that all surveyors in state work in the same tier. The reason this was an issue, they were saying, well, what if Montgomery County's doing too good a job of inspections and the rest of the state is not being inspected? We're going to get fined for that. Do you really believe for an instant the feds are going to penalize the state for doing too good a job? The question for the deputy secretary is, what have the fines been for the complete failure over the past 5 years of inspections? Anyway, to that point, I said, put in writing where it states that. All right, I'll wrap up. Madam Chair, it doesn't exist. And I would love the opportunity to keep dispelling the myths that have been presented to this committee and to my finance committee. Colleagues, this bill passed unanimously in the Senate Finance Committee, and every member of that committee asked to be amended on as a co-sponsor because they said, we have got to do this. Madam Chair, off record, I would love to discuss the fiction of the fiscal note. It does defy logic if Montgomery County is going to eat half the cost of doing this, as it would, or any jurisdiction under this bill. The fiscal note should be zero, and in fact, the federal government's paying the state to do it. If Montgomery County eats half those costs, and Montgomery County wants to,
Thank you.
That's the reality. No, thank you, Madam Chair. I appreciate your indulgence. As you can see, this is an issue that troubles me terribly. These are the most vulnerable people in our state.
I can tell you, and I appreciate your, your passion, your patience, your concerns, all of that, all those attributes. And I can tell you that the department and you have an amazing person who crossed the bill, the vice chair of this committee. I actually sat down with the department and our staff regarding this bill. You don't know about it, but we did this week trying to get to the bottom of it. So I know because it's really important to you, but it's really important to my vice chair as well. So just to let you know that we're working on it. I know there are a lot of questions, so I'm going to start with the first one that I saw. You took it off. So I don't know who was first. I'm going to start with Delegate Riley, who doesn't ask many questions.
Appreciate that. I think it's a fairly easy question. So when we heard, because I remember the House bill and I had on my notes, we had Dana Kaufman and also Mako that were favorable with amendments. Does the Senate version have those two amendments on it?
Correct.
Okay, thank you very much.
Yes, thank you.
Delegate Morgan, to my left, just to be fair.
Thank you, Madam Chair. Senator Kramer, you mentioned the total cost that the department was receiving from the federal government, but I missed that.
I'm sorry, I beg your pardon.
I'm sorry, I didn't speak into the microphone.
Yeah, I don't hear quite the way I used to, Delegate.
Well, either do I, unfortunately. You mentioned in your testimony the amount of money the department was receiving from the feds to conduct these inspections, but I missed that. What was that?
Yes, so I was able to get information, but the federal contract with the state provides that every year the state is to submit to the feds their budget for the year for doing these inspections. Okay. And I asked, and I was able to get the numbers for the following fiscal years. Fiscal year 20, $3 million. Fiscal year 21, $3.944 million. Fiscal year 22, $3.3 million. Fiscal year 23, $3.5 million. And fiscal year 24, $3.7 million for doing these inspections. And I will share with you that during that time in Montgomery County, the most populous jurisdiction in the state, Montgomery County was averaging 1 to 2 nursing homes in total being inspected of our 34 nursing homes.
Real quick follow-up, Madam Chair. So the range is the last 5 years is between $3 and $4 million in federal money.
Correct.
But yet they've only inspected 24. I think you said that in your testimony, 24 inspections.
Well,
per
they
year?
state according to the Deputy Secretary, as quoted by WTOP, there were 47 nursing homes inspected of the in fiscal year 24. 47 of the 222 nursing homes were actually inspected. So one of the important questions is the state being fined for its failure to fulfill its contract with the federal government? It's an important question. It's not been answered.
Okay. Well, thank you for your testimony.
Thank you.
All right, next I have Delegate Hutchinson, followed by Johnson, followed by Hill.
Thank you, Madam Chair. Thank you, Senator. This is not just Montgomery County.
No, this is every jurisdiction in the state. In fact, some jurisdictions had gone 2 years with 0 inspections in their counties.
I have a nursing home in small Dorchester County, but when I first came in office, I had people say that they were putting their loved ones in there, and I cringed, and they died. It was a place to go die, and they're not getting any responses. We're not getting any responses on what's going on in that nursing home. So thank you for bringing this, but am I hearing you correctly? I stood on the House floor yesterday saying how much money we don't have on Dorchester County, and you're saying that Montgomery County is willing to pay for half of this. And we have a $3 billion deficit in our budget, and the state health department is saying, we don't want your money, we don't want you to do this. Am I hearing this correctly? Is that how I'm understanding this bill?
I think disappointingly, this has become a turf battle rather than what's in the best interest of our residents. And for 20 years, Montgomery County was doing this, and as of the last 10, Montgomery County was eating 60% of the cost. We paid for our own surveyors to do this work and paid for 60% of their costs. Now, the department has since created a fiscal note claiming they will need all kinds of personnel to oversee Montgomery County now if Montgomery County were to go back into doing the surveys. That's total fiction. It didn't exist before in the 20 years. They did not have separate personnel that were hired to oversee Montgomery County, but in order to create a fiscal note, because they're well aware of the death by fiscal note, particularly this year. So they've created one, and I'm confident you're going to hear all of the misinformation about that following me. But the fact of the matter is, yes, Montgomery County ate 60% of the costs. Under the bill, it would be 50%. And any jurisdiction under the bill, and really the bill started out as a Montgomery County bill, but then I had colleagues in the Senate saying, wait a minute, we looked into this. Our nursing homes have not been inspected at all. So maybe our county government is willing to pony up half and start doing what Montgomery County had been doing and would like to do again. So I had several of my colleagues say, will you make it a statewide bill? I said, sure, I understand. And I would challenge each of you to please get information from the department about the inspections each of the last 5 years in your jurisdictions, and be very specific, because they will play games with numbers. Tier 1 is the most basic. That's just walking in and doing the inspection. When you get to Tier 3, that's when they're supposed to come in during off hours, like late at night, early in the morning, when nobody's expecting them to come. We're not even touching that at this point. We're way behind on just the very most basic Tier 1 general inspection required annually by state law, at most 16 months by the federal contract that the state has. So the answer to your question is, yeah, the county's willing to eat half the cost.
Thank you.
Thank you for the question.
All right, I have Delegate Johnson, followed by Delegate Hill.
Thank you, Senator, for this bill. This is important. I was reading the fiscal note before you mentioned it, and I was a little confused that there is a fiscal note for something that they're already supposed to be doing. So can you speak on that just briefly?
Yes, well, once again, they're being paid by the feds to do this. And under the bill, that's why, and thank you for the question about the fiscal note, because in the fiscal note, to kill the bill, they indicated that they have to hire, I believe it's 3 personnel of different categories just to oversee Montgomery County doing this work. So with that, they were able to create a fiscal note. Now, the fact of the matter is, the county never had these state personnel overseeing anything they did. They did their work just like all of the state surveyors, and they sent in the information to the state, and the state would send it off to the feds. The difference is Montgomery County had a perfect inspection record of getting the nursing homes inspected as they should every year. Since the state took it back, they've been going totally uninspected, and I will share with you that there was a conversation I had with the deputy secretary a week and a half ago, because the deputy secretary sent me a letter and said, oh, look at all these nursing homes that we've inspected in Montgomery County. So I asked, I said, well, wait a minute, how is it that suddenly Montgomery County nursing homes are getting inspected as this bill is moving through? So the deputy secretary, using the deputy's words, oh, we're not trying to juice Montgomery County to make it look like the inspections are getting done. But the fact of the matter is, colleagues, in the last 2.5 months, suddenly Montgomery County went from 5 inspections in all of 2024 to, I believe, 10 that were done in the last 2.5 months. So that means, to the detriment of your jurisdictions, they are in fact juicing the inspections of Montgomery County to be able to come in here and say, oh no, we're getting caught up, we're on top of this. Who do you think is suffering that suddenly Montgomery County's nursing homes, and they're still way behind, they're not even close, But yes, so they have created a fiscal note, and you're going to hear, I'm guessing, a whole lot of misinformation about how this is actually going to cost the state. But I guarantee you for 20 years when Montgomery County was doing this and paying half the cost, it was not costing the state anything, or they would not have contracted with Montgomery County to do it for 20 years. So unfortunately, again, it has become a turf war, and that's a shame. They should have just simply renewed the contract. And I'm telling you all, if you go back, check your numbers, you may find that it's appropriate for your jurisdictions, if they choose, to start doing the same. Thank you for the question.
Thank you, Madam Chair.
You're welcome. I have Delegate Hill, followed by Warman. Then Chisholm.
Senator,
Good afternoon.
always good to see you, sir.
Always a pleasure to see you, my friend.
So let me ask, I remember when we had the House bill, and I was confused about the opposition. Let me ask the question, in the 20 years, are you aware of any problems with the quality of the inspections that were being done with by Montgomery County? Were there inadequacies or inappropriate reports? Were there deficiencies that weren't being cited, or anything that would have rolled back to MDH to make them feel like they had to take it back because Montgomery County could not do the job well?
None whatsoever, and thank you for the question. Once again, Montgomery County had a stellar record of not only doing the Tier 1 inspections, but being up on top of all four. Again, there's 4 tiers. Tier 1 being the most basic. That's just put eyes on the nursing home once a year. No, Montgomery County was doing, and to be honest with you, in 2021, when the contract lapsed, I believe it's because of COVID that it just was overlooked. There was our Department of Health was overwhelmed during the COVID time, and so this contract lapsed, and I don't think people realized, hey, wait a minute, this agreement that's existed for 20 years just expired. So when it did come to surface, the county reached out to the State Department and said, hey, we've been doing this. Can we get the agreement renewed? And they were met with silence and silence and silence until it was brought to my attention. And I said, wow, 1 year ago, the then Secretary of the Department of Health came into the Finance Committee and said the reason the inspections weren't happening was they didn't have the personnel. So I simply asked, well, then sign the MOU with Montgomery County, and you've got the most populous jurisdiction out of your way, and now you can focus your resources on the rest of the state, your limited resources. This was 1 year ago. And she said, well, no, the contract, we're going to have to pull in all kinds of attorneys from different departments, yada, yada. I asked for a copy of that document. Colleagues, it's a total of 16 pages in which 14 of the pages are boilerplate contract language like you would find in any contract. Here's who's responsible for liability, insurance, and these things. 2 pages had to do with the plug in the numbers.
Well, one follow-up. And during the time, the 20 years that you had the contracts, are you aware of Montgomery County's nursing home facilities had fewer complaints from families, fewer injuries, fewer bad outcomes because they were being inspected regularly? Did this help them to be a better quality than the average across the state, or you have any information about that?
I do not have that information. Logic would dictate that that would be the case, particularly because Montgomery County was way ahead on investigating complaints than the state has been. So, when a complaint came in, Montgomery County was on it, as opposed to, as was stated by the Deputy Secretary just 3 months ago, there's 6,000 complaints in arrears. And I guarantee you, by the time those are addressed, those people will probably have been discharged and there was a lawsuit filed this past summer against the department for their failures because people were being left in soiled clothes, unbathed, uncleaned. They were not getting their medications. There's a suit that's been filed against the department because of their failures in the nursing homes. Thank you.
Delegate Warman and Delegate Chisholm, and then the last question will be Delegate Collison. We have a lot more stuff coming up, all right, in Shalega, okay?
Thank you, Madam Chair, and thank you, Senator Kramer, for bringing this very important bill. As a Montgomery County delegate, I'm very happy to hear that they're willing to restart this program where they do the home inspections themselves. So, you know, I'm relatively new here, just got appointed last year, but, you know, I want to ask a question that might seem, you know, a little, it struck me as a little peculiar. So we ask our agencies, like the Department of Health, to provide input during the fiscal note process for the bill, which makes sense given their expertise, but then some agencies can then come in and use that fiscal note to fight back on what it is that we're trying to get done here. Is that the way that it's working out for this bill right now?
Yeah, I'm not sure I fully understand the question, but the issue with the fiscal note, and again, this was brought up over on the Senate side, and it was agreed that it defies logic that it's going to cost the state money if Montgomery County's eating half the cost, or under the bill, any jurisdiction. What's also interesting is I reached out to the Department of Health in Montgomery County last week and asked what the training period had been when the county had it. Much of it was done online. It was a very short matter of weeks because now the department is claiming that it takes one existing surveyor to train a surveyor. It has to be done one-on-one, and it'll take a year. And that, they're claiming, inflates the cost. Montgomery County had 9 full-time people who just did the surveys. And the county, again, paid for 60% of those costs. That meant the state did not need to hire those 9 positions, or if they had the positions, they could focus them in other areas of the state. So there's a lot of question in Montgomery County about what I will again say is a fabricated fiscal note, and that it was done with the sole intent and purpose of death by fiscal note for this bill. Thank you for the question.
Okay. Delegate Shalega, Delegate Chisholm? No, it was Delegate Chisholm and then Shalega. Go ahead.
Thank you, Madam Chair.
You're welcome.
And thank you for bringing the bill, Senator. Fiscal note's a problem, but I want to talk about previously. You went through a litany of numbers that you repeated back to Delegate Morgan, and from what I gathered, it was about $3 million a year MDH was getting to do these inspections, and the number you gave was 46. And I looked at that, and that's about $65,000 to $70,000 per inspection. And then I looked at if they were getting $3.5 million and doing an inspection on every single one we had in the state of Maryland, it's 222. That's about $15,000. Did they ever give you any insight on what they actually did with the money? If we weren't doing the inspections, or if we were doing the inspections, how were we spending $65,000 to $75,000 per inspection? Is there any line item, detailed report that was ever given to anybody on where the money actually went?
I asked that, thank you for the question, because I asked that very question, and I received a response that they don't have the details on that. So we have no idea what happened to those millions of dollars received by the federal government that clearly did not go into inspecting the nursing homes. And again, that begs the question, was the state fined or punished somehow for its failures? Because they brought up a concern that, once again, if Montgomery County is doing too many inspections and gets ahead of the rest of the state, that they might be subject to fines. Once again, it defies logic, and there's nothing that documents that. And in fact, the Montgomery County attorney was asked to look into that very issue, and they said they could find nothing. And I've got a copy. They refer to what's called as the CMS policy, and I took a look at that, and there's nothing in there. But yes, it's a good question. Where did that money go?
Right. Thank you, Senator. Thank you, Madam Chair.
Thank you for the question.
Last question, Vice Chair Collison. Thank you, Madam Chair. Thanks for bringing this bill. So I actually Googled it, and you can look up the nursing homes, and you can look up their last inspection, just like you said. One of the ones in my district hasn't been inspected since 2021.
There you go.
So do they get fined? Does the state fine them? Is there a consequence? I'm thinking these nursing homes want to be inspected. We've had a similar issue with funeral homes, kind of lack of inspection. So do they want to be inspected, but they aren't inspected? Do they get fined? Is there a consequence?
I am not aware, and again, I will repeat, just saying, and thank you for the question, and there you go. Perfect example. 2021 hasn't been inspected in 4 years. Now, these are the most vulnerable, and nobody's putting eyes on the condition. I think it's a great question. I don't believe they have been subjected to fines. I know under the contract, because I've got it, they could be, but I'm guessing the feds have been waiving the fines, even though we're tied for second to dead last with Alabama for failing to do these inspections. And I believe, if I understand correctly, there's only 11 states that are failing the contract. We are way, way, way down on the bottom of failing. We are mega failing. And that's because you're looking at right now, live, real time, the CMS website, that nursing home hasn't been inspected in 4 years. And even if they start getting caught up, they're still going to be way behind in the cycle because they're catching up on nursing homes that haven't been inspected in years. They're supposed to be under state law, 12 months. The feds will give them an extra 4 to get it done, 16. But I think that's an excellent question. Have they been penalized and fined? And I suspect they're not.
I would hope not, because clearly they would want to, I would assume they would want to be inspected. Most nursing homes are good actors that, they're trying to do their best. One last question.
Well, and real fast to that point, I was asked about the question of, as amended, the nursing homes were supporting it, and the amendment reflects what it was they were seeking, just clarifying language. And they came in and supported the bill.
Right.
It's only the department that's opposed. Nobody else, no other organization, group, or individual.
How many inspectors did you have in Montgomery County when you were functioning, things were functioning as should be?
We had 9 surveyors.
9 surveyors, okay.
Correct.
And how many nursing homes?
34.
Okay. Thank you.
And by the way, folks, we're not even talking assisted living facilities. Holy smokes, that's another topic altogether. We're talking nursing homes, but that is an issue.
All right. Vice Chair
Collison. Thank you very much, Madam Chair, and thank you, Senator, for your passion.
Thank you, my good Vice Chair.
You know I share your passion. I absolutely do. And I know that OHCQ was not doing its job for a long time. And I worried about that too, which is why, I wanted this bill. We are in, and the other thing that I think has happened is OHCQ was not being held accountable in the past. So on this side over here, I've been told over and over again that I can't argue with a fiscal note. What the fiscal note says is what I have to abide by. So I was working and have been working with so my question is going to be to explain what I've been working on and ask you if you're open to any of it. I've been working with the department and the governor's office to find a way that we could meet the goal, of the bill without a fiscal impact. And so I've done some amendments. I'm going to be proposing some amendments that do three things. One is to hold the department accountable by requiring regular reports to the locals about how many nursing homes in their jurisdictions have been inspected over the last 6 months. So every 6 months, they're going to do that report. They're also being required to report to us on an annual basis in terms of how often the nursing homes are being inspected. And then there's a trigger that says if they get behind, then a locality may choose to augment, not supplant, but augment the survey schedule by hiring on its own dime a couple of surveyors who would be a part of the state team to continue to be able to do their work. But my amendments also make it very clear that the Montgomery County surveyors could not be restricted in any way on the tier progression. So they would be able to respond to complaints in a very timely fashion. This is a way I think that we can, and it would apply to all states, to all counties. It provides for the opportunity to increase the stable of surveyors, but it holds, most importantly, it holds the department accountable for making sure that the work is done. Are those things anything there that you could talk to us about, think about, look at? Your thoughts, sir?
Well, let me begin by saying I am very grateful that the vice chair of this committee is one of my District 19 colleagues, and love her to death, and very much appreciate her interest in trying to find ways to get things done. But with respect to your characterization about the fiscal note, I am not ready to abandon the conversation if we can have that opportunity here in the House. The Senate acknowledged that the fiscal note defied logic. It simply defied logic.
So,
and
if I may?
Yes, ma'am.
We usually don't do this because then we're working the bill, right? We do a lot of work in subcommittee, and I have already allowed you a lot of leeway.
Agreed.
And because I know you, because I know how much time you have spent on it, right? And we still have to vote, and we still have many hearings, and your colleagues are waiting. So that being said, I could tell you that the fiscal note is what we have, and we're stuck with it, and we have 11 days left in session. So that being said, let's assume that's not on the table. Can we work on the other things that are on the table? And that doesn't mean we're going to abandon it, but I am realistic too of what I'm going to be told by, people that are above me, okay? So, so let's just keep it simple.
Understood and appreciated, and if that is going to be, all I can say is, in response to the vice chair's thoughts, if we had done this a year ago, Montgomery County would have had 34 nursing homes inspected in the last year instead of 5. So I suspect that we can do something. At the end of the day, I'm not sure what it will accomplish, but the bill is in this committee's hands. And what the committee sees fit to do, I guess, will be taken up when or if and when the bill comes back across the street. But I just, you know, it's in your hands, Madam Chair, Madam Vice Chair, and the hands of this committee. And all I can say is take a look what's happening in your neck of the woods. And that's all I got for you, Madam Chair.
Well, thank you so much. Look, this is an important issue. There was a similar bill introduced in Prince George's County. You know, I represent Gorgeous, Prince George's, and Gorgeous Anne Arundel County, right? And we're trying to deal with it. And I feel your frustration with the fiscal notes, because those of us know and have seen it and know how sometimes, you know, they are, the number is higher than what we expect, okay? And the fiscal writers work really hard, and I appreciate their work. And it's also 90 very intense days as well, right? So in the, just know, and I want you to leave here knowing that we are going to try to find a solution, and this is the year, okay?
And I'm not disparaging the fiscal note writers, Madam Chair, but if you look at the fiscal note, what their source for it, the information was, the Department of Health.
Okay. Well, thank you so much. And,
Thank you, Madam
if you could stay
Chair.
in touch with your wonderful sister from another mister and my vice chair on this bill, that would be great, okay?
Thank
Because
you.
we're going to try
Thank you for your
to,
indulgence.
we're
I
going to
appreciate
compromise.
it.
You're welcome. It's, you know, out of respect, because I know you spend a lot of
We've
time on
always
it.
been friends, and I thank you for that.
You're most welcome.
Thank you, committee. I appreciate your indulgence as well.
So we have 2 witnesses left on this bill. If we can bring a favorable with amendment, the department. If I can have the Maryland Department of Health. Is it just going to be you or, okay,
Yes.
okay. Good afternoon.
Good afternoon.
I do not want to be in that seat.
I've been here
Just
before.
kidding. Thought I would break the ice a little, okay?
Well, first of all, good afternoon, Chair Pena-Melenik, members of the committee. For the record, I'm Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health at the Maryland Department of Health, and was so generously quoted in the prior testimony. With that, I do want to say that I'm here in support with amendments. As noted, the department really does take this seriously. I have been before this committee. We provided a briefing, testimony on this bill. We take this seriously. And we know that we did not step up during the pandemic, as did most other states in the country. Not an excuse, but an explanation. To that end, we have made a lot of strides in improving our care. We started this fiscal year at 23% of nursing homes surveyed. That is bad. We are up to 57% today, and counting and improving. We have put into place contractors to get us caught up. We have put into place process improvements. We have hired all of the 13 surveyors that were provided for us in this fiscal year, and they are in training. And once they are done with training, and it takes anywhere from 6 to 12 months for that training to happen, that is per CMS, they will then be able to accelerate the pace of our work. You heard some numbers from Montgomery County. We have done 22 of the 34 nursing homes in Montgomery County this year, this fiscal year so far, and in the state, we have done 84 total. We are moving, and we are continuing to move. Our concern with the bill as written is that it would start taking, if a county requested, it would carve funds out of the department and start slowing us down. We would have to fire people. That is what happens if you take our funds. And we don't want to compromise our progress in this arena. Vice Chair Cullison noted what some of the amendments are. I'm not going to repeat them. Those are amendments we support. We absolutely welcome investments from counties. I'm going to say it again. We absolutely welcome investments from counties. If I may, your indulgence.
You could take the extra time.
Thank you.
Go ahead.
What we don't want to do is start carving up our budget, making it harder for us to move, and we are still responsible as the state agency for the survey work that CMS delegates. And so even if that money is carved out of our budget and we have to fire people, We are still responsible for what happened in the county. And that puts us in a precarious position. And so while we did have a contract with Montgomery County, we had it with multiple counties. And we spent a lot of money and personnel overseeing work instead of doing it. So that's the issue that we are trying to manage here. And I support our accountability. We should be accountable. The numbers I'm telling you will not show up on the CMS data set yet. It takes 3 to 4 months to show up. But I will gladly, to every member in this room, give you the dates of the surveys in your county that have happened. And you can see the progress we have made and that we will continue to make. And so it's for that reason that I strongly encourage support with the amendments that Vice Chair Cullison noted, right? Accountability, the ability to augment our work as counties choose. We happily welcome that. And that, I think, is the best way forward for us as a state. And so I will stop there, and thank you for your indulgence.
Thank you. And thank you for working with us, okay? And just to give some, actually, why don't I just ask my question at the end? I don't know who was first. Who was first, Hutchinson or Johnson? Okay, Johnson, let's just do then Hutchinson and then Shalega, okay? Johnson.
Thank you, Madam Chair. Right here, Madam Chair.
I was looking at Shalega.
And thank you. So on that information that you're going to get to us about how many inspections,
yes,
can you let us know how many of those are Tier 1, Tier 2, Tier 3, and Tier 4? So we not only know how many inspections, but what kind of inspections are being done. Are you just showing up and putting eyes on the facility, or are you getting to the more in-depth inspections? So if you can have that on the information you provide us, that would be appreciated.
I will do that. I just want to note that Tier 1 and Tier 2, we're in Tier 2 right now.
Okay.
And that speaks to when also the hours that we're coming out, so off hours, evenings, weekends, and less to the depth of it. But we can include the types of surveys that we're doing, because we do more than just the annual surveys.
Okay, if you can include that.
But yes.
Thank you. Appreciate it. Thank you, Madam Chair.
And did I say Hutchinson and then Shalega? Okay.
Thank you, Madam Chair.
You're welcome.
Doctor, thanks for being here. A tough spot to be in this afternoon. So I don't follow this because my understanding is that in this case, Montgomery County is willing to pay for their inspectors. And you're saying if you do that, then the department has to fire people. Why do they have to fire people? And with a $3 billion deficit, is losing a few people because they're being paid for by Montgomery County a bad thing? I just don't follow that at all, that logic and that line of thought.
Sure, no, I understand. So the way the bill is currently written, it requires the department to share half of the cost, meaning to provide it to the county. If that money is taken from the department and given to the county, we cannot support the salaries of the people that money supports. We would have to fire them. There is no way for us to find additional dollars to give to the county and preserve our staffing.
Then why can't the county hire the people that you're getting rid of out of the department?
They may be able to. I'm not saying that they couldn't, but I'm saying that that would reduce our ability to be able to first conduct the survey activity, and that presumes that the county is going to be able to fully staff up and be able to do whatever they need to do. Remember, during the pandemic, this wasn't a failure of the department alone. Everyone in the country was falling behind, right? Because we were not allowed to do annual surveys.
But if it worked for 22 years, why is it not going to work now?
It wasn't working because the department was spending more money overseeing, coordinating, and not surveying, managing a number of different contracts, right? It wasn't just one county. And that's why I keep saying, we're happy for the county to invest. We're asking, and I'm asking, that we don't ask the OHCQ to carve its money out and start divvying it up across counties. If the county wants to add additional dollars, please, by all means, we are happy to sign that agreement right now.
Just one point of clarification.
Yes.
All along I've been hearing, and am I not hearing this right, that Montgomery County was willing to pay for this? You're saying that Montgomery County's taking the money out of the state health department's budget?
Correct.
Or is Montgomery County paying for it out of their budget?
The bill as written requires OHCQ to take money out of its budget and transfer it to a county.
Okay, thank you. Thank you, Madam Chair.
Thank you. Delegate Shalega, I'm looking the right way now.
Thank you.
You're welcome.
How long does it take to do an inspection?
It takes typically about an annual survey inspection takes about a week, about 4 to 5 staff to do it.
1 week, 4 to 5 people?
Mm-hmm.
Yes, I'm
Now-
reading a report here. It's very granular. Observations of breakfast tray and beverage room delivery service, blah, blah, blah. So yes, that's why I was asking. It looks very, very granular. And then you provide these inspection forms. They're all uniform because, as I said, you can look them up online. They're all posted there. You provide them to CMS?
So yeah, so once we do the survey, we have to actually provide the report to CMS. They review it. They might have questions or requirements. Go clarify this. Go out for reinspection. There's a little back and forth. Usually that's not too much, but there is some back and forth because it is ultimately their survey.
Okay, and does CMS tell you, this is what I want you to do? I mean, they're looking at dishwasher temperatures, like it's very granular here.
Yes, we're following the federal standards and guidelines for what we need to do.
So they say, go out, we have this checklist of 400 things, and then you fill them out and type them up on this form and send it back.
Correct.
Thank you.
Okay, I don't see any other questions, but I do want to say, for the record, and some of us have been here a while, this is a problem that has been around for a long time, right? Different administrations. And as a matter of fact, you hire a new person now to head the department that you're not. Can you
Correct.
tell the committee that?
Yes, so I'd like to introduce Tia Witherspoon, if you could stand up. She joined OHCQ as the executive director approximately 5 months ago and has done a great job in actually turning around the work that we're doing, both in the long-term care facilities, in the assisted living facilities again, and looking across all of our work.
And you're also looking to hire new people, right, to do these inspections?
We are not looking. We have hired. We have completely hired. We have 2 vacancies out of 65.
And I know I was talking to you and I was excited because I said, wow, I didn't know those jobs existed and they pay quite well. And you said people can apply how? And tell the committee what is the training that it involves for someone to do this job.
Sure. So typically we're looking for somebody with a clinical background. We have predominantly nurses, but other clinical positions are open, dietitians, social workers, so on. There is a training, there's a required federal training. It's called SMQT certification. It takes 6 to 12 months. It requires a test at the end of that, and only at the end of that are you able to then actually be a surveyor. So we are paying for staff to go through training. In the past at least 6 years, we have not hired a single person who has come to us with SMQT.
And it's a one-on-one training, right? You have to use staff to train staff?
Yes, so we have there's some training in the classroom, and we have an instructor who does that, and then there's in the field training where you're paired with a surveyor who is training you, and that surveyor works a little bit more slowly because they are working with a student.
Okay, well, this is the most effort I have seen done to sort of clean that office, to staff it. And I hope that we can come to an agreement on the amendments. And I can tell you now that this committee will be having a briefing, God willing, we're all around, on January next year when we have a session. This is one of the, and I'm letting staff know, this is one of the hearings, briefings that I won in this committee. And I'm going to be asking you, so that you're not surprised, how many have you inspected? What counties have you inspected? How many people do you have? Where are we, right? And if you are behind, you must ask, and I know the amendments are going to allow for the counties to be able to give you the help. And I'm going to be asking out of the 23 counties in Baltimore City, 24 jurisdiction, a little over 6 million people in Maryland, and 200 and something facilities, how many have you done? Okay?
Happily, we will be happy to be here and to demonstrate our progress.
And I take your word at it. I do, because we work very well together. And I know you always keep it. Thank you so much, okay?
Thank you. And thank you
have
to
a
the
great
committee.
evening. There's a Leslie Frey. Not here? Okay. Not here, okay. All right, this concludes the bill hearing on House Bill 376. I want to take a minute to say thank you to the senators who are waiting, who have been extremely patient. You can go blame Senator Kramer, just kidding. Okay, but it was an important issue, and you know what? We will give you the same respect. If you had an issue like this in this committee, you will get the same time, the same commitment, and the same respect, okay? So let's go with Senator Hershey, Senator Bill 773, and this is Health Benefit Plans Calculation of Cost Sharing Contribution Requirements. And you have one witness to speak in favor, and he's right there to your left.
That's right.
All right. Thank you for your patience.
Thank you very much, Madam Chair. For the record, Senator Steve Hershey to present Senate Bill 773. And this is the result of 2 years of compromise between both the House and Senate. The intent of this language has always been simple: to make sure that when a patient receives copay assistance, whether in the form of whether from a nonprofit or a drug manufacturer, it counts towards their deductible and out-of-pocket maximums. Without this protection, insurers and pharmacy benefit managers can take that assistance, not count it towards a patient's cost sharing, and force the patient to pay more out of pocket. Senate Bill 773 ensures transparency, fairness, and predictability for patients struggling with serious, chronic, or rare diseases. Madam Chair, in the spirit of compromise, this bill was amended in the Senate to address some of the concerns that we heard in that bill hearing. We included common definitions of carrier and high deductible plans, and we also added industry standard notification language. As you know, this bill is very similar to Delegate Johnson's bill, which was just heard over in Senate Finance. And Madam Chair, Vice Chair, and Delegate Johnson, I am very appreciative that you gave me the opportunity to speak with you before this hearing. I think we are very, very close to getting over that final hurdle. And with that, we can finally come to an agreement on this legislation. So with that, again, I'm looking forward to working on that last issue and hope for favorable support. Thank you.
Next, please.
Thank you, ladies and gentlemen. For the record, my name is Lance Kilpatrick. I'm the Government Relations Director for the American Cancer Society Cancer Action Network. People with cancer and rare and chronic diseases such as HIV, MS, and hemophilia can undergo a great deal of suffering. And amazingly, there are medications that can ease that suffering, but to do that takes the best that healthcare has to offer. In the United States, that does not come free. Patients with cancer or other rare and chronic diseases often have to seek out financial assistance to help them get better. And just like the myriad number of rare and chronic diseases, the forms of financial assistance that a patient may be eligible for can come from many different places in many different forms. It could come in the form of copay assistance. It can also come in the form of pharmaceutical assistance for those with no insurance or are underinsured. Or it can come in the form of a charitable contribution, whether it come from a foundation, a church, even a Good Samaritan. But the point is, my good friend, the senator, said, Senate Bill 773 ensures that all copays count. 21 states, including Virginia, West Virginia, and Delaware, as well as Washington, D.C. and Puerto Rico, have passed bans on copay accumulators. An analysis by the AIDS Institute found no evidence of a meaningful impact on average premiums. In recognizing that each patient's needs are unique, notification language has been added to ensure the patients know ahead of time the total amount of assistance available to them and the duration for which the assistance is available. Thank goodness, not all patients need assistance for a full year, but many do need that full assistance at the exact time that they need it. The informed patient can determine for themselves if this arrangement works for them, giving them assistance, information, and flexibility to focus on healing, which should always be the #1 goal. I strongly urge this committee to provide a favorable reporting of Senate Bill 773. Thank you.
Thank you. Any questions, Delegate Johnson?
Thank you, Madam Chair. Not a question, but I just wanted to thank Senator Hershey for working with the House on this bill. Our goal is the same, and I appreciate it for the citizens of Maryland. Thank you.
Thank you as well, too, Delegate.
Vice Chair Collison?
I want to add my thanks to Delegate Johnson's thanks to the senator. And you are absolutely right. We have worked hard together on this, and I also think we're very close. I wanted to ask, just for the record, so the goal of the bill has always been that any assistance count towards the deductible. And I'm assuming that's a correct, because we've been working on this bill for 2 years. It was never about necessarily paying the full deductible up front. So the question I have is whether you are able to articulate what the copay assistance from a manufacturer actually, and a PBM, I can't believe I couldn't say that, when they adjust the cost to provide assistance to the patient, what happens to the payer's portion of that cost?
Well, thank you for that question, Madam Vice Chair. So as I said, there are myriad forms of assistance that get proffered, so it's difficult for me to be able to answer that question with one specific example, right? So sometimes the cost goes directly to the patients. Sometimes it goes to the specialty pharmacy, which frankly is also often owned by an insurer or something along those lines, right? Sometimes, like I said, it's a direct contribution to the patient itself. So I think that the key thing that I would point out that we really like about the Senate bill is the fact that it takes into account different circumstances that each patient may or may not have. A friend of mine within the industry just recently, God bless her, has overcome a cancer diagnosis. She had 5 months worth of medication to take care of her unique situation, right? She didn't have to have assistance over the duration of her individual plan year, but she did need that money in the beginning because of taking care of the deductible. And I would also add taking care of any co-insurance, right, or maximum out of pocket that may occur beyond the deductible going forward. We know that a lot of these expensive specialty medications have copay requirements beyond the deductible going forward. So depending upon the type of assistance they get, they could very well address all of those things or at least a partial part. And I think the great thing about the notification requirement that is in this bill is that the upfront knowledge of what that assistance will be and how they are going to receive it for what duration of time can then, like I said, have an informed patient make a decision if that's the best situation for them going forward.
So just to clarify, because I understand there are many different, kinds of assistance, but I'm thinking primarily of the drug pricing chain. And the assistance, there's no cash exchanged. It's simply a paper dollar amount. There's the charge to the payer, and I gave the example earlier this year where I pay $30 for my Cosentyx, but my insurance company pays $10,000 for my Cosentyx. So if I was getting assistance on my Cosentyx, say $1,000, then my insurance is only paying $9,000 instead of $10,000. And I think that's the reason, that kind of predictability, which the drug cost of an insurance company ultimately contributes to the premium cost. So we're looking for a way, and it's not easy because the whole thing is so complicated, to balance the consumer needs on both ends, right? On the end of point of sale, the need for the medication, and the cost, the overall drug cost to an insurance company or a payer in order to make those amounts less as well.
Yeah. And Madam Vice Chair, if I may, two things. Again, one is, ensuring that the patient gets the assistance when they need it, right? What I believe you're referencing is the concept of a maximizer over the duration of a planned year, potentially?
Doesn't have to be. There's nothing in the language, there's nothing in the language that
There's nothing in the language of
requires
Senate
that.
Bill 773. That's true. And I would just want to point out for the committee on that specific issue, which is not necessarily relevant for this bill, but that the Federal Employees Health Benefit Plan has specifically not permitted maximizers within any plan that is offered to federal employees, which includes literally millions of enrollees going forward.
I believe and I'm sorry, Madam Chair, if you want, we adopted in our House bill the language from the Senator's bill that would prevent the use of maximizers by the carriers.
Okay.
Yeah.
We actually did.
Yes,
Yeah.
we did.
Yep. Any other questions? All right, seeing none. Thank you so much, Senator.
Thank you very
Will
much.
you let us know so we can get this done, please?
Certainly will. Thank you all
Thank
very
you
much.
so much, and thank you for your patience and for meeting with us today. We're really grateful. And all of you, thank you for your grace in being patient and waiting. This concludes the bill hearing on Senate Bill 773. We have the very patient Senator from District 47, Senator Augustine, who waited a while for us. So he's here for Senate Bill 60. And it is actually Maryland Medical Assistant Program and Health Insurance Recovery Coverage for calcium score testing. Thank you, Senator, for your patience.
Thank you, Madam Chair Peña-Melnick, Vice Chair Cullison, members of the committee, Senator Malcolm Augustine here on behalf of Senate Bill 60, which in substance is in the same posture as House Bill 666 by Delegate Woods. Madam Chair, there was just a couple of words in the purpose paragraph where they're not exactly the same. I would ask that you pass the Senate bill in its current form, and I just ask for a favorable report.
And those words don't change, do not
No.
change the fiscal note or anything like that?
Right. On the substance, these are the exact same.
Wonderful, just for the record. Any questions for the good senator? All right, no questions, and thank you for being so gracious. Thank you. You have a wonderful,
Y'all
blessed
too. Have a good
evening.
day.
This concludes the bill hearing on Senate Bill 547. Is Senate Bill, what is it? I'm sorry. Senate Bill 60, I apologize. And I was thinking ahead. Senator James was here. Okay. All right, let's do it. Hey, who was here first, Spencer
I
or
believe
Senator
Spencer
Guy?
was. I don't want to jump him. You called the
Let
senator.
me call
so-
him first.
Please.
I want to be fair.
No, I'm.
Senator Giles, represented by Spencer.
Thank you, Madam Chair.
And Spencer, you were certainly definitely here before.
Thank you.
Thank you for your patience. And this
Thank
is
you.
this is Senate Bill 357, the Prescription Drug Affordability Board. Spencer, thank you for being kind. Go ahead.
Of course, thank you. I came over here because my boss had been promoted to chair, but she's probably been vacated at this point. So for the record, Spencer Dixon, Legislative Director for Senator Guile on her behalf, here to present SB 357, which is the cross-file of HB 424, sponsored by the Vice Chair. Thankfully, it doesn't involve nursing homes, so we should. Or maybe nightmare, but they are in different postures. So before passing the Senate with bipartisan support, SB 357 was amended in the Finance Committee to add additional reporting requirements to the board after it sets an upper payment limit, along with adding members of the PDAB Stakeholder Council representing the rare disease community, oncologist, and patient advocacy organizations. The committee also adopted the amendment requested by MDH requiring further coordination between the PDAB and Medicaid. It is my understanding that the Vice Chair and hopefully the committee at large is fine with these amendments. Additionally, I understand the following 4 amendments are being considered or will be considered soon by the committee. First, adding, quote, to the extent practicable to the new reporting requirements for the annual report, understanding that the board will study each of these issues to the best of their ability based on available data. 2, it clarifies the language to state that the board may not apply upper payment limits to drugs in shortage to align with the existing statute and process for how the board currently manages drugs in shortage. 3, that upper payment limits will be set through regulations as discussed and approved in the current upper payment limit action plan. And 4, clarifies the language on the payers and purchasers that are preempted from this work. The previous version listed specific types of entities, but we've provided clearer language that addresses the same issue. Senator Guile supports these additions to the bill, and she will also work with the Finance Committee to add them to the House bill after conforming it to the Senate bill. As such, I would respectfully ask for a favorable report on SB 357.
Thank you, and I have actually spoken to my vice chair, and she is fine with those amendments. We'll just bring it to the committee and make sure that the committee is also fine with it as well. I want you to thank the senator for working with us. As always, it's a pleasure to work with her. Are there any questions? Vice Chair Collison.
Not a question, Madam Chair, but thank you for your indulgence. Just please tell my best friend, Senator Guile, that I look forward to working with her on this and other bills going forward. It's
of course,
and
to
great
quote
collaboration.
To quote her, you are her bestie, so she appreciates it.
And Delegate Bagnall is jealous at this point. Okay, I'm just saying, just speaking for her, okay?
District bestie.
Yes. Thank you so much.
Thank you,
Have a
Madam
wonderful,
Chair.
blessed evening. This concludes the bill hearing on Senate Bill 357. We are on to the last bill of the day. And then if you could stay, we're going to go down on your seats. We're going to vote very quickly. We have next Senate Bill 547, Senator James, Commission to Study Health Insurance Pooling Establishment. Good afternoon.
Good afternoon, Chair Peña-Melnick, Vice Chair Collison, members of HGO. I appreciate the opportunity to testify. Unfortunately, Senator James had to be called back to JPR. I shouldn't say unfortunately, but she had to be called back to JPR. For the record, my name is Samuel Deschanel, Senator James's legislative director, here testifying on her behalf to present Senate Bill 547. So this is just a straightforward bill that's just about saving money and efficiency, which is, two very relevant topics this year. The bill just establishes a commission to study the pooling of public employee health insurance purchasing between the state, counties, municipal corporations, and county boards of education. Like I said, the goal is simple. It's just find efficiency, help save taxpayers money. That when Senator James was when this was first brought to Senator James's attention, she was thinking back to Maryland's long history of doing efficiency, or of being efficient. Back in the 80s, they enacted the local government investment pool, which kind of does a similar thing with states' retirements and pension systems. So this bill is just creating a commission to look at health insurance pooling. Generally, being part of a large health insurance pool is regarded as an effective way to manage risk and keep costs down. Several other states have been doing this, and this is just to get Maryland to look at if we should do it as well. That's more or less the bill. I'm happy to answer any questions you all have. Thank you.
Okay, thank you. Former delegate Dan Morheim, who used to be on HGO. Nice to see you. Will you give us your testimony, please?
Thank you, Madam Chair, members of the committee. This is the perfect health and government operations bill because it includes both health and government operations. If you were in the legislature in 2018, you voted for an earlier version of this bill, House Bill 1400 in 2018, which passed unanimously. And I appreciate first Senator West, who got me connected this bill to Senator James, and the entire Senate Finance Committee signed on as co-sponsors. It really is about pooling. Insurance is a pretty simple concept. The bigger the pool, the more the risk is spread. Right now, basically, we have the state buying health insurance for like 100,000 people. And this is all my testimony in the article I wrote that you have. And then we have the 24 counties and 24 school systems, each also buying health insurance. There's some cooperation there, but fundamentally it's 49 entities buying health insurance. What if we all bought health insurance together? The chances are overwhelming that not only would there be savings, and it's a big number, health insurance is a big number, so 1 or 2% or 5% of savings is a lot of money. And the only other way the state gets money is raising taxes or cutting programs, both of which have their challenges. So, and not only that, workers, the state employees would get better coverage. The original bill had a task force, and the task force did make a recommendation on a whole separate aspect of the original bill, but it definitely agreed that this makes sense. So the first bill was enabling, and you might ask the question, why hasn't this been done? If this is such a good idea, why hasn't this been done? And there are a lot of reasons. They fundamentally go around, people are uncomfortable changing the way they do business. There's some local interests, vested interests, and so forth. But it's always the right time to do efficiencies. It will take some work. It's not hard work. It's just basically like we used to call in the legislature, side by side. How much does this cost? What do you get compared to what you're getting now? And I think what everybody would find, and the preliminary analysis that we did for the original bill, and I think again now, would show that there would be savings, and you'd be providing state workers, county workers, school system workers better coverage for less money overall. It'll take some work, and that's the purpose of this commission, and I hope you will support the bill. Thank you.
And thank you for your advocacy on this and many other issues. We really appreciate it and your help.
I'm going to say too, I really enjoyed listening to the hearings. You had some great stuff going on today, so it was impressive. You're doing a great job, and I appreciate it.
Well, thank you so much. I have Vice Chair Collison, followed by Delegate Taveras.
Thank you, Madam Chair. It's so good to see you, Dr. Morheim. Let me say that I knew about the enabling legislation, and I spoke with our county budget folks a couple of years ago and said, why wouldn't we consider this? We could have pooled with the state and increased, our insurance pool really significantly and positively. And I was told that there was a feeling that they could get a better deal negotiating it themselves as opposed to the bigger pool. Are you aware of any other states that are doing this kind of pooling actively? And if we've actually seen the benefits from it?
Would you like me to answer that question, or?
Sam, do you want to take it, or do you want?
If Delegate Morheim wants to take a first shot at it, by all means.
Okay.
The answer is, I checked with NCSL when I first put the bill. About 10 states were doing it, and now that was in 2018, and now it's over 20 states. You can reconfirm that. I haven't checked in about a year or so. There are different, each state operates differently. So some states, it's been the major metropolitan groups that have gotten together, but the rurals in other states, it's been the rurals that join in because they have limited buying power. So there's different versions of it because of the matrix of the way each state is constructed. But fundamentally for our state, really not, 6 million people, and 24 schools and 24 county jurisdictions in one state. I'm going to tell you one other thing personally. I had state insurance for 24 years. It was the best. It was better than when I worked for a ER staffing company. It's better than I worked for a hospital. It just makes sense. You're going to do that. And health insurance is so important to people, so why not get them the best? Now, you do need to involve, besides running the numbers, the stakeholders, teachers, firefighters, police, all the workers that work in these entities need to be at the table, and they all supported the bill through their own organizations, TAPCO, MSTA, AFSCME, and so on back in 2018. There's no opposition to this bill, but everybody would have to be at the table and work through the process and then make that decision. Does this make sense or not? The problem has been getting over the hump, and that's what this bill attempts to reignite. And let me last thing, it shouldn't take a fiscal crisis to be smart in our spending.
Thank you. If I could follow up, Sam, does the senator have a list of those 20 states and what they are doing?
Not every single state. However, in the bill file, there should be a report. I think it's from 2008, so it's a little dated, but it has a list of it. I believe it's 11 states and a little bit more background as to the savings.
Great,
And
I'll take a look. Thank you very much.
Yep.
And I think Sam could call NCSL and get the up-to-date version if you need it.
Yep.
But it still makes sense for us regardless. Thank you.
Okay. Delegate Taveras, followed by Hill.
I think that Delegate Cullison asked a lot of my questions, but I'm just trying to make sure I'm understanding who ultimately would be responsible for managing the pool and selecting, which are the critical issues that we're going to cover under the plan.
Delegate Morham, do you want to take that one?
It would be the entity that buys health insurance for state employees now, which is the Department of Budget and Management, as I understand it, the one that buys health insurance for you if you get your state health insurance. So it would not be, in my county, Baltimore County, the few people in Baltimore County who are now handling that and dealing with the maze of stuff. But everybody gets into the pool together, and then the risk gets spread and the coverage improves.
Thank you.
Thank you. Good to see you, Doctor, former delegate. And you related to Warren?
Yes, Warren is my father.
Very good. Well, he's a good man, and we can see you don't fall far from the tree. So I'm trying to get an understanding. I know that we have our state plan, local jurisdictions can participate, and according to the fiscal note, there are 28 municipal corporations already participating. And then I think you referenced that in 2018, we did a task force to study cooperative purchasing. They came up with recommendations in 2019, included increased outreach, analysis of potential costs, et cetera. I'm not clear on whether the pooling we're talking about through this bill is different. And if not, with the findings in 2019, what new findings or up-to-date findings do we think this group would come up with that why is this not doing the same thing we just did?
As I understand it would be the same, if I understand your question, it would be the same. But since the counties and the schools have not taken this up, and it is 8 years later, it made sense to take a fresh look at this issue and see where the benefits and where the concerns might be, so they could be properly addressed. That's the purpose of this bill. So operatively, it'd be the same as 2018 when it passed, but now we have a different, set of circumstances, and so that's the purpose of the review. Do you want to add anything?
No, it took the words out of my mouth, more or less. Okay. I was just going to say it's basically to reinvigorate the discussion.
So the discussion, and to either of your knowledge, did we ever survey before we even do a study again of the benefits? Have we ever surveyed and said, why haven't you all chosen to pool with us? I mean, in other words, we're trying to answer a question, but we may not have found out what their issue is, and so maybe.
I believe it was touched on in the report issued from 2018 about why, Delegate Moran, please correct me if I'm wrong, about why counties haven't done it. It doesn't go in depth on it, and it certainly hasn't been a more recent review asking them why they haven't done it since then. So I certainly understand that question. But I believe, sorry, go ahead, yeah.
No, that is the purpose of this bill, to identify that. The surveys have not been done, and that work needs to happen, and that's what this bill intends to do, so that should it come back again in some form, we'd have good information to be able to answer those very pertinent questions.
All right, thank you.
Right, so there are no further questions. Thank you so much for being with us today. Delia Morheim, we miss you, and thank you for being here. Please give our love to the senator. This actually concludes the bill hearing on Senate Bill 547. Thank you. Have a great day. Thanks. Will you guys stay seated for a second? Bring us down, please. And we have a little voting to do. Remember, we're voting every day, and I want to thank everyone for your patience.